So hello, everyone. Thank you so much for taking the time to be with us today. I know how full everyone's calendars are. I'm sure a lot of you are working, whether that's from the office or from home, like myself. I'm sure a lot of you have children, and I know it's school holidays at the moment, so it's a bit of chaotic time. And so having all of you in the room today still through all of that really tells us that this topic really matters to you. So if you haven't been in one of our webinars before, I'm Sarah Jane. I'm the founder of Own Your Hormones. My team is also in the background listening. And we are South Africa's first health and hormone conference and education platform. So our goal is not to be the professional that knows everything about these hormonal topics, but our goal and our job is to bring the right people into the room and bring the people that should be together. So we really want to bridge the gap between the clinic, online information, and the community, and really bring hormone health into the spaces where women are living, working, and making everyday decisions about their bodies. So thank you again for being here. A quick few things before we get started. Your mics and cameras are off for all attendees. And the reason is just so that everyone feels super comfortable. The session is being recorded, so if you need to step away, you won't miss anything. We will upload the session onto our YouTube channel as well. But please do drop your questions into the chat as we go. While Dr. Tharushka is speaking, if something pops up, drop it in the chat, and we'll leave some time at the end to get through as many of those questions as we can. As you know, today we're talking about PMOS. You may know it by its older name, PCOS or PCOS. And yeah, part of today is us unpacking why that name change matters and getting into more nitty-gritty details about it. So with that being said, I have now said more than enough. I would like to hand over and introduce you all to Dr. Tharushka Naidoo. And Dr. Naidoo brings a homeopathic integrative lens to hormonal health, and today she is going to be walking us through PMOS, and we're super excited and grateful to have you with us today, Dr. Naidoo. Quick thing before Dr. Naidoo takes over, I do just want to mention that she will be speaking to us in a very comfortable, cozy manner. That's why she's got her phone propped up. We'll be chatting to us. We're not going to have any slides or make it too technical. We want you to feel like this is almost as if you were sitting in the office having a real conversation with Dr. Naidoo. And secondly, because Dr. Naidoo practices from a homeopathic perspective, certain questions about conventional medical treatments usually fall out of her scope, and so they won't be covered today. The focus for today is to keep it on natural and sort of holistic approaches that she specializes in. So with that being said, Dr. Naidoo, over to you.
Thank you so much, Sarah Jane. I really appreciate it. And I'm so grateful that you've opened this platform for us to educate so many women on the topic, especially we're in a time where there's so much of information and there's information overload from social media. And I think when we hear it from a professional or the professionals, then it's just a little more credible. Let's just put it that way. So just to give you a bit of background on who I am, Dr. Tharushka Naidoo. I'm 37 years old, a wife and a mom of two beautiful girls. And I've been in practice now for almost 10 years. And something that has really been close to me and treating is female reproductive health, just because I've seen many patients struggle with this, and it just sort of steered me into that direction to study further and do more research into it. And I suppose that's why I'm here today. So as you all know, we are going to be talking about PCOS, polycystic ovarian syndrome, but of recent, the name has been changed to PMOS, PMOS, polyendocrine metabolic ovarian syndrome. So I'm going to be talking about why this name is changed, why it's important that this name is being changed, because now we're identifying the root cause. Just to also go back to talking about the root cause, myself as a homeopath, this is really what we look at. So just for those who don't know what homeopathy is, it's a form of medicine, and it forms two major parts. Is that the medicine we prescribe is derived from natural sources. So in terms of side effects, it's little to none. But the main aim of our medicine is that we look for the root cause of conditions to prevent it from progressing, and of course achieving healing and health. And this is what I aim for in a lot of patients of mine, all my patients of mine who come to me. And I can say that I've had much success with PCOS as well, or PMOS, because we can get women to get back to a place where they are PCOS free or in remission, as we would say. But as I get into more of the details and talk about it clinically, it is important to understand that with this specific syndrome, there is no cure for it. And that's why it is so important to treat somebody as an individual, but also when I say holistically, I mean in the true sense that we need to take into account their mental health, emotional health, as well as the physical symptoms that would probably take them to their doctor's rooms in the first place. And then acknowledging that diet and lifestyle and sleep play such a huge role in this. And it's probably the best way in which to manage this condition. So if we get down to it, what it is, polycystic ovarian syndrome or polyendocrine metabolic ovarian syndrome. I know it's a lot of words, but I want to break it down for you so there's an understanding of what it is. So poly meaning many, endocrine, understanding now that it's not just a female condition, female reproductive condition. It involves so many different hormonal systems in our body. So that's where the endocrine comes in. And metabolic, which is the key thing about it, is that we understand that insulin is the driver, and we do need to treat that because it really is tackling the root cause of it. And I'm going to explain to all of you how insulin plays such a major role. Although we thought, insulin is a hormone that controls our glucose, there's so much more to it. And I'm going to explain exactly how insulin plays this role in progressing this condition. Ovarian, because of course it does affect the ovaries, and it's the issue with ovulation that comes in with the hormonal imbalance that we see. And the word syndrome versus disease. A syndrome means that it's a combination of different symptoms. And I can see 5 patients in a day with PCOS, and every single one of them will present differently, because in a syndrome, not every patient will have all of those symptoms. Okay, so now that we've broken down what this new name or new term means, if we look at what could possibly cause it, it's no one single thing. I get this question by a lot of moms who come to me, say, what can I do? What can I implement? Can I give my daughter anything to prevent this? Like, what causes PCOS? And really, there isn't one specific cause. But if we do look at genetics first, those individuals who do have family members who are diabetic do have a genetic predisposition to PCOS. And we understand this because insulin is the driver. So I will explain later on how insulin actually works normally in a healthy individual to help you understand why it's so important to manage the diet. But if you have anybody in your family, so that could be either parents, grandparents who are diabetic, that means that you need to take extra care of yourself to not allow the genes. So genes are like a light switch for it to be switched on. Because conditions like diabetes, it's actually not inherited. We can prevent it from developing, but we need to be more mindful of our health. So those young women who are going into puberty, who are in their teens, need to be more mindful, and moms need to be more mindful and say, okay, I need to help my daughter. I need to steer her in the right direction when it comes to her food, her lifestyle, because I see a lot of teens who are really not eating well. Of course, stress levels, high school relationships, it's quite a difficult time emotionally for a lot of young teens. And so we need to support the younger generation. And hopefully by doing this and educating, we can also prevent more and more women from getting this condition. So genetics is one of the root causes. Also, if we look at women now in their 20s and 30s and even 40s who may start developing PCOS, it definitely comes from the lifestyle that women are leading today. So I will talk about stress and sleep and diet and how now versus 2 to 3 generations ago, when our moms, grands, great grannies were eating less processed food, there was less hormones, more veggies, more fruit, more whole foods. Women were not also, I would say, as stressed. We live in a time where financially now women and partners have to work in order to sustain a household. So maybe stress also was a little less back then. And we see this also with the fertility rates, that a long time ago, women were not having issues with being able to fall pregnant. You could hear of women having, I mean, I know in my family, 5, 6, 10 children, whereas now we're seeing with conditions like PCOS and endometriosis, women even struggling to fall pregnant. So these are all factors that can possibly cause a woman to develop PMOS. And so if we start implementing these lifestyle changes, we can prevent it from progressing, also prevent it from developing altogether. So now that we have some information on that, I do want to talk about the symptoms. And of course, the whole subject of our talk today was that these symptoms are not random and that they're all connected. So if we look at how we diagnose a patient, this actually forms a very important part of the treatment process because, well, as a homeopath, and this is why I'm talking from my practical experience in private practice when I'm seeing my patients, it's really understanding what they are experiencing and what they have as an individual. And this is where the treatment plan comes in. So we've got to say, right, this patient was given the diagnosis of PCOS. Do they really have it? Is it a different hormonal issue? I do get some patients who maybe are diagnosed by one doctor and then another doctor says, oh, I did your ultrasound, there's no cyst, so you don't have PCOS. This is one of the reasons why the name was also changed, because you don't need to have ovarian cysts. In fact, it's not common to have cysts in PCOS. So this is why the name is being changed. So when we are looking at an individual, the first thing we've got to look at is her periods. The periods are really important, and it's not just about having a bleed every month. It's about the health of that period. And the reason why I say this is because a period shows us, and if it is healthy, and there's certain things that we look at in a period, which I actually want to talk to you about as well. There's certain things that we look at that can tell us, does this woman have good hormonal health, good hormone levels throughout the month in the 2 phases of her cycle? So ovulation is actually the main part of our menstrual cycle. And if a woman is not ovulating regularly, her menstrual cycle can go off and become irregular. So this is one of the first clues that we look at, because there's 3 criteria, in fact. So the first thing is, does this individual have irregular or regular menstruation? If it is irregular, then it tells us they are not ovulating regularly. Do they have anovulatory cycles, meaning they are not growing their egg, and so they don't have periods? I do get patients coming in, they'll say, Doc, I don't know, I can't remember when last I had my period, or I don't track it anymore because it's so erratic. I stopped using my app because it's completely off. So a really important part of treatment is not regulating the period, but getting that patient ovulating again. That's the most important thing. Now, ovulation actually goes off in PCOS because of the hormonal imbalance. So initially we thought, okay, well, is it just estrogen, progesterone? Maybe if we just give the patient these hormones, then the periods should regulate. So those of you who maybe are on birth control might understand this. Oral birth control is similar, not obviously exact, estrogen and progesterone. And so it's given to a patient who may be diagnosed with PCOS to give her those hormone levels to build up her lining. And then when she gets to her placebo, she bleeds, right? So it's a withdrawal bleed. It's not a true period when you're on birth control, because a true period is basically a result of no pregnancy and your lining is shedding because you ovulated and did not conceive. So just to go back to what I was talking about is that when we are looking at ovulation, it's not just important to look at those two hormones of estrogen and progesterone. It's important to look at what else can happen in a woman that can possibly suppress her ovulation. And this is where testosterone and insulin come into play. And this is why the name is also changed, because insulin is a big driver of that. Insulin is a hormone that controls our glucose, as we know. But the effect that it has in the ovary, because our ovaries have receptors, so it's like a lock and key. This is how hormones work with our cells, like a lock and key. So our hormones are like the keys, and every single cell has like a lock. So this hormone comes in and it locks into place and it does its job. But when there's too much insulin and it goes to the ovary, it makes those ovaries produce too much androgens, which is testosterone. So this is where we see a lot of the physical symptoms come up in PCOS, and that would be acne breakouts, the triad, acne breakouts, hair loss, hair thinning on the head, but then an increase in hair growth on the face and the body, and that's called hirsutism. So when we have more testosterone, and that's not what the egg needs, it stops ovulation. So this can also cause the irregular menses in patients with PMOS. But the testosterone is also what causes those physical symptoms. And as a homeopath, we always do like detective work. We always take a step back and say, okay, but why is the patient making so much testosterone? Oh, it's the insulin. What is their diet like? So you've always got to keep taking a step back and look and try to figure out what the root cause is. Because if we just treat the end result, so for example, if a patient takes a pharmaceutical medication, say for the acne breakouts, I get this a lot where a patient will say, my acne cleared while I was taking it, but then it came back. It's because you didn't address the root cause of the problem, which was the testosterone. So when I start treatment with the patient, it's really looking at their periods and making sure that we get them ovulating. And we do this with homeopathic medication, and it must then start coming regularly. For those of you who also don't know what a healthy period is, and I know it's a funny thing to say, but I see women all the time that actually have never had a healthy period because maybe their PMOS started in their teens, or they were so accustomed to having period pain, having heavy periods, light periods, irregular periods. So you don't know what's normal and what's not normal. So what we aim for in patients, even with PCOS or even with hormonal imbalances, is for them to get a period every month. So that's approximately 28 to 30 days. And how you calculate this is day one that you start bleeding is, the first day you start bleeding is day 1. And you count 28 days from that, so that's about 4 weeks. And then the 28th day is around when you should be getting your next period. And this is now what we need to aim for in patients with PCOS, the regular ovulation. The second investigation that was part of the criteria was the ultrasound, but in recent months, it's no longer part of the diagnostic criteria. But just to go through with you, what we see on an ultrasound is when we look at the ovary and a doctor tells you, oh, you have a lot of cysts. So just for an understanding of what is the difference between a follicle and a cyst, we did get this question a few times come up. So a follicle is what keeps the egg inside. It houses the egg. So our brain sends FSH, follicle stimulating hormone, to the ovaries to stimulate the growth of these follicles. And then as these follicles start to grow, our ovaries produce estrogen and it grows the egg inside this follicle. So that would happen in a normal situation in a healthy individual. And then as that egg grows and it matures by day 14, right? So that's textbook, but of course this can change. That follicle will burst and the egg is released. But in patients who have PMOS, what happens is because you don't have the correct levels of estrogen to grow an egg and maybe more insulin and testosterone, your egg is not growing. And so those follicles end up sitting and lying dormant in the ovaries. And your brain picks up the signal. It says, why is there no eggs growing? And it sends more and more of the follicle stimulating hormone. And more of these follicles start popping out. So when you go to the gynae and they scan you, they'll say, oh, you've got lots of cysts. The word cyst and follicle, unfortunately, is used interchangeably, but to explain the difference, a follicle is something normal that we would see in an ovary. The size, if you are scanning, depending on where you're scanning a patient in her menstrual cycle, if you are doing it near to her ovulation, the size can actually go up to 25 millimeters. That's 2.5 centimeters. That is okay. That's a normal follicle size, but they range in size. You'll get different sizes in the ovary. And you get about 3 to 5 of these follicles that will be visible. But because in PMOS, you are not ovulating and your brain is overstimulating the ovaries, so many of these follicles start popping out. And then when they scan you, they'll start to say, oh, yeah, you've got like 10 or 12. They called it the pearl necklace before because you'll see all these little dots around the edge of the ovary. What happens in an ovarian cyst is because now those follicles are lying dormant in the ovary for a long time, they can become inflamed and draw fluid and then can become quite painful. So a true follicular cyst, an ovarian cyst, is when it's about 3 centimeters and bigger. So it is also important if you're going to your gynae, ask them, what are the sizes? How many do you see? Because that can give us some insight as well. Although you can't only do an ultrasound to diagnose somebody. So if you've had your doctor say that, you should insist on blood tests also being done. And your doctor should be going through a thorough medical history with you to understand what your menstrual cycles are like. You can't diagnose somebody only with doing an ultrasound. So that's the second thing. And then the third thing is we look at now blood tests. So I've mentioned a couple of things just now, but a good panel that you should ask your doctor for, and this is the panel that I send my patients for, is the basics. So you would do a full blood count. Then you would do inflammatory markers because we see an elevation of inflammation in PMOS. So that would be what's called ESR and CRP. Vitamin D, very important for hormonal health and optimizing your egg quality and ovulation. Then just as a standard, an iron profile, vitamin D, folate, thyroid, so your TSH, T4, T3, and sometimes I do include the thyroid antibodies. The reason why it's also important to do this is because there are many symptoms that actually are the same in an underactive thyroid and PMOS. So that could be weight gain, hair loss, irregular periods, even fatigue. So you need to make sure that you also are dealing with the correct hormonal imbalance, or if not both, because I've had many patients who have been diagnosed with PCOS, but then we also later on detect an underactive thyroid, which is, of course, adding to the problem. And then your HbA1c, which is an average glucose over 3 months, and of course, fasting insulin. So it's really important to do the insulin blood test, because now that we know it's the main driver of PMOS, the way in which this test needs to be done, a 12-hour fasting test. So what needs to be done? The patient needs to stop eating any food by 7:30, 8 p.m. and no food after that. They could drink water if they needed to, but the morning of the blood test, they go in around the last time they would have eaten, so about 7:30, 8 a.m., and have the insulin checked. A good insulin level is a fasting insulin of between 4 and 7. If it starts to climb above that and we're seeing 10 and more, then this is now slight insulin resistance that now we need to treat, because we know it's the driver of PMOS. And then if a patient comes to me and she hasn't had her period for more than 3 months, and she is used to that erratic, those irregular menses, then I would also include the hormones. So that would be FSH, LH, estrogen, progesterone, and prolactin, and of course the main one, her testosterone. So free and total testosterone. So now that you have an understanding of all the things that we look at, I do want to discuss these physical symptoms that come up. And I know for a lot of women, the weight is probably the first symptom that takes them to the doctor's office, actually even well before the periods for them are an issue. So where the weight is coming from. So if we talk about a healthy individual and the workings of insulin, when we know what's normal, then we can identify with what's not normal. So insulin is a hormone that is released from a gland in our body called the pancreas. It's released in response to when we eat sugar or carbohydrates. So if we understand our food groups, proteins, carbohydrates, fats, all carbohydrates break down eventually into glucose in the gut. And so insulin is the carrier. So I use the analogy of, think of insulin as the Uber and glucose is your passenger. So your insulin goes, picks up glucose and takes it where it needs to go. Because insulin, being a hormone, can receive signals, it knows how to get to the receptor. Glucose doesn't know anything, right? So when we eat a carbohydrate or we consume sugar, and we taste that sweetness. And this is really important because the conversation about artificial sweetness will come in a little bit later when we're talking about nutrition. But when we have that sugar or those glucose or high GI carbohydrates, that signal is sent and insulin is released. So then insulin takes a hold of that glucose and it takes it to the cells that require energy. So our muscles use the most amount of energy because we're constantly moving it. Then we've, of course, our heart cells, our brain, and then the rest. But when we are eating these high GI diets or consuming a lot of sugar, then what happens is insulin picks up the sugar, takes it to the muscle cell, knocks on the door, hi, I have glucose here, please let it in. The muscle cell stops responding because it could be one of two things. There is still glucose in that cell because that patient is not exercising. So I'm going to talk about how we can effectively try and reverse insulin resistance. And it's really important when we talk about the exercise. So insulin comes with glucose to that cell. Hi, I have glucose here. Please let it in. The muscle cell maybe doesn't respond. So this is an insulin resistance. It's been exposed to so much of insulin all the time, it loses sensitivity, right? Or because that person is not exercising, like I mentioned, there's still glucose there. So what does the body do? The body then takes it to the liver, and glucose is converted into fat and it's stored away. That fat is essentially stored glucose. All right. So that metabolic pathway, and so this is why it's PMOS now, that metabolic pathway continues and continues until at a point your cells don't respond well anymore to insulin. And so this is what insulin resistance means. So when you are eating those high GI foods, the white flour, the sugar, it automatically just gets converted into fat. Now, where the difficult part comes in is that I see patients who maybe go to their gynae and the gynae says, well, if you want to treat your PCOS, just go and lose weight. Okay, so I'm going to try and do that. Right, so I'm going to start eating healthy, I'm going to cut down on my sugar, and I'm going to start exercising. But nothing happens. You still remain at the same weight, or you still continue to gain weight. And the reason for this is because your cells are not sensitized to insulin. So no matter what you do with the diet and the exercise, it's still not going to be effective enough. And so for me, a very effective protocol that I've seen is that we have to do all three things at once. The three things that I'm talking about to try and reverse insulin resistance, to help reduce testosterone production, to help one lose weight and regulate their menstrual cycle, is to change the diet. And we've got to remove that sugar from the diet. We've got to reduce the refined sugar from the diet. Anything made with flour, really, white flour, especially high GI. So that's your white bread, rolls, pastas, noodles, pastries and pies and all of those things, cakes and chocolates and sweets. I can understand that the cravings are quite intense because the brain is sending signals for you to eat more sugar. It wants that. So we've got to change the diet. That's the one very important thing, which I'll get to talking about what are the things that one with PCOS can do. We've got to move the muscles because and build up muscle if the muscle mass is low. The reason why you have to exercise and that there is no quick fix in reversing insulin resistance or losing weight is because the reason why we've got to move those muscles is you want to use up the glucose that is stored in that muscle. And you need to give the body a reason to start taking out fat from storage because this is a normal pathway. When we start reducing the amount of sugar and carbohydrates that are going in through the mouth and you start exercising, the body's like, wait, what do we do now? There's not enough sugar coming in. This body is moving. These muscles are moving. We need energy. So what happens? The liver works in this process. I'm not going to get too technical, but then fat is taken out of storage. It's converted back into glucose and it goes to your muscle cells. That's in a normal individual. But when there's insulin resistance, there needs to be some sort of medication, at least to assist that person in sensitizing their muscle cells or all of their cells to insulin again. So a lot of patients are prescribed metformin or glucophage, as it's known, and GLP-1s, which I'm not going to be touching on today because, as Sarah Jane mentioned, it's not specifically my scope of practice, but it is being used just because we understand that insulin is a driver. The reason why I educate my patients on this whole pathway is because when you understand why the diet is so important and why exercise is so important, it pushes you to do those things and not try and find a quick fix and give your body that time that it needs for healing, because patients tend to use try to use quick fixes and then maybe gain the weight back just as quickly when they stop using it. But if we change our approach and we identify and say, if I can change the way I'm eating, and I understand now why I have to exercise, if I want to allow my body to use this fat as energy, then this is the things that I need to do. So as a homeopath, I prescribe inositol. So I'm sure many of you must know what inositol is. It is a natural supplement. The reason why it is recommended is because if we look at the ovaries, it actually contains inositol in its natural amounts, and in a ratio of 40:1 between myo and inositol, and this is why the ratio is recommended. The benefit of inositol is that it does help with ovulation, but it also is an insulin sensitizer, just like how metformin and glucophage is. So that is what I prescribe. But that's why it's important that one needs to reduce their high GI foods. I don't believe in low carb diets. I believe in the right carbohydrates. And so that would come from your veggies and your fruits. We can have some grains. So I would say a low GI basmati or brown rice would be recommended. Sometimes quinoa, but keeping to whole foods would be the best. Okay, so now that we're on the topic of nutrition, if we look at our main food groups of protein, carbs, fats, I advise my patients that 2 out of their 3 meals to help with balancing their blood glucose levels, now in the attempt to reverse insulin resistance, protein needs to be prioritized. So for most people, if you're not a breakfast person or don't like eating a lot in the morning, then it needs to be where you are having a sufficient amount of protein for lunch and dinner. So instead of saying, well, I'm going to make a sandwich or I'm going to have a pasta, even if it's brown or lentil pasta, we need to change our thinking to say, okay, I need to choose my protein first. So you say, okay, I am having chicken for lunch. Can I pair this with a salad or veggie first before I choose a different carbohydrate, before I choose the wrap, before I choose the sourdough bread? Try and go for the carbohydrates that are whole food, that are natural, which is your veggies and your salads. You can do the same for dinner as well. Choose your protein first. By you doing that, you start to prioritize your protein intake. And then for dinner, you could say, right, if I'm going to have curry, then rice is fine. I don't have anything, I'm not opposed to that. It's just the quantities that are consumed and the type of carbohydrate. Once you have that, then you know, okay, you're prioritizing protein. I do advise all my patients to reduce drastically their refined sugar. That's white and brown, obviously. Artificial sweeteners as well. So even if you're drinking diet soda, it's still going to have an impact on your insulin. And the reason for that is, I mentioned before that when it comes to our digestion, that actually starts from the mouth. So with our tongue, when we taste something sweet, that is already sending signals to our brain to say sugar is coming. You know, as humans, we think we're very clever. We've made artificial sweeteners, but we aren't tricking the body. Yes, you won't have a glucose spike, but your insulin will still be released. And so this is why it's important that we start changing what our palate wants and having more savory foods instead of sweet things. It can be very difficult initially when one starts to cut out sugar because the cravings can be very intense, but there are natural supplements that one can look at, and even homeopathic remedies that can help in assisting cravings. Even inositol can do this. So we need to combat that and push through, because in order for us to change that metabolic pathway of how your insulin is behaving, you have to change what you are eating. Now, other things that can influence insulin, And remember, this is the main driver now of PMOS, is stress and sleep. So if we look at sleep, it's not merely just the quantity, the hours that you're getting in. It's also the time at which you're sleeping, because there's certain things that need to happen at specific times at night. For example, our liver detoxification happens generally between 10 p.m. and midnight. So by you pushing late and say, well, if I sleep at 1, I can wake up at 7 a.m. and I've still got my hours of sleep, so I'm okay. It's still not okay. I advise my patients to try and be in routine as much as possible. Consistency is key. Sleeping at the same time, waking up at the same time every single day, because it also assists with insulin regulation, because the lack of sleep is also stress on the body. As women, we are definitely more sensitive to stress, and that merely comes down to the fact that our bodies and our anatomy was designed to hold a fetus. So if the body is too stressed, our reproductive system is the one that takes the knock first. Our body says, nope, this body is too stressed. We shouldn't be focusing on making estrogen and ovulating and reproduction. We need to focus as a human being on surviving, and then prioritizing sending those vitamins and nutrients to the brain, to the heart, to our muscles for survival. So if you have PMOS, or if you have a hormonal condition, it is really important to prioritize even your mental and emotional health, because those stresses can be setting you back. You might be taking all your supplements, you might be eating well, exercising, but if you don't treat yourself holistically and manage those other areas, then healing will take a lot longer if you see it at all. So sleep is really important, because there are studies that show that even one bad night of sleep can affect the way your insulin behaves the very next day. So sticking into a routine is really important. And if we talk now about mental health and we talk about stress, I did mention earlier that stress is a big role player in a lot of women's health issues today, but stress is always going to be there, and we can't avoid it. We can't run away. It might be our work situation, relationships, home, just the normal stresses of life that we are experiencing today. So we need to look at ways and means of managing it, because we can't avoid it. So that could be things like breath work, making sure that we are getting out, getting sunshine, getting fresh air, taking a moment to just step back from the busyness of it and understand that our mental health is just as important, because of cortisol and our stress hormone can also influence insulin. So many of you probably have come across the word cortisol before. That's our stress hormone. And what it directly influences insulin. So back to insulin. When we are stressed, we still have that, of course, human instinct that if we are in danger, it's like fight or flight, we need to fight or we need to run away. In order to do that, you need glucose to your cells. So what the body will do when we are stressed, it will release insulin in order to take glucose to our cells, because I need to fight a lion or I need to run away. But it could just be that you are under chronic stress with work or kids or husband or whatever it is. But your body is releasing this insulin, making your insulin resistance worse, making weight loss worse, but it's coming from your mental and emotional health. So we can't only look at the physical things, and we can't only look at medications that only work on our diet and glucose levels, because our stress levels and our cortisol play such a huge role in insulin as well. So we need to manage it. There are, of course, natural supplements that one can take Even many patients come to me for anxiety and depression and respond so well to homeopathy when you don't want to be taking anything with side effects. Because the reality is sometimes it can be really hard to manage your stress and your emotions or even PMS just with going for a walk or those physical activities. Sometimes we need a little bit extra. So I want to emphasize that when you are diagnosed with a condition like PMOS, it is so important to make sure that you are acknowledging that I'm stressed, I need to do something about it, and just not do everything else, because you could be wasting your time, your energy, money on expensive supplements, buying things online, and you don't even know if it's working for you or not. So we've talked about stress and the role that cortisol plays on insulin. We've talked about sleep, nutrition, exercise, and why all of these are really important. If we go through some of the questions, we can do that. I'm just going to quickly scroll down to see if we have gone through everything. Sarah Jane, are there any? I know we've still got time, but are there any questions that you've got? I've seen quite a few pop up as I was talking, because I haven't really touched on the homeopathic approach yet on treating PMOS, but I wanted to know, are there any questions that you would like me to go over first that's related to what I've spoken about?
Sure, there's a few questions. Some of them I think you have answered, but I'm going to repeat them again in case something else pops up in your head or if there's something additional. So thank you everyone for your questions. The first question is, and I'm not sure if you can answer this just when it comes to your scope, Dr. Tharushka, but it said, hi, is there a way to manage your weight and keep it off with PMOS without taking metformin and GLP-1? If so, what would the food intake and exercise look like? Which I do think you have answered that, but I don't know if there's anything additional you want to add.
Well, you see, if we have to, because to make it a bit more individualized, and this is why individualized treatment is so important, because there's no one size fits all, okay? So what I do recommend to patients is doing a body composition scan, which is a scan that can assist one to figure out what their metabolic rate is, how much of muscle they have on the body, and what is their body fat percentage. The reason why it's important is because you could be eating a lot of healthy food and followed, like what I've said now, and you're prioritizing protein, but you could still be eating too much. So you could be exceeding the calories that you should, right? So that's when we look at metabolic rate. So if one is still trying to lose weight without having to use metformin or GLP-1, because just as a side note, metformin and glucophage are not weight loss drugs. They do not help with weight loss. It only helps with sensitizing your body to insulin. So you still have to do the work. If you take glucophage or metformin, you still have to exercise, because remember I said you have to give your body a reason to want to take out fat from storage and use it as energy. Metformin and glucophage just tell your muscle cells, recognize insulin again. It's an insulin sensitizer. That's the same thing as inositol. So even if you're doing those things, in order to effectively be able to reduce your body fat mass, you need to change the diet, you need to do the exercise and take the medication. But to make it a bit more individualized for that person, it would be good for them to try and get that scan done. There are, I mean, I have it at the practice, there are some gyms that have it, there are dietitians that have an in-body scan or a DEXA scan, and it gives a patient a lot of insight compared to just jumping on the scale. Because when you start the process of changing your lifestyle, and you're just jumping on the scale, if you start working on building up muscle and you jump on the scale and then you see, oh, I've gone up 1 or 2 kgs, it could be that you lost 5 kgs of fat, but you've gained like 7 kilos of muscle. So the extra is 2, but you're not realizing internally that that shift has happened. So that's where the benefit of the scan can come in for patients with PMOS.
Okay, great. The next question is, and I hope I pronounce this word correctly. Hello, thank you for this platform. I have a question about hirsutism. Is there a way to reverse this condition? What are natural remedies that's going to help stop the hair growth? And I'd also be interested to know if that is something that's connected to PMOS, just to add on to that question.
So if we go back to what I was talking about, hirsutism is the increase in hair growth, right, on the face and the body. It predominantly will come under the chin, under the jawline, on the chin, upper lip, the sides of the face, sometimes on the chest, around the nipples, that's the areola, and even arms and legs. The reason why this happens is because both men and women, we have receptors for testosterone in those areas. In men, of course, because they are producing more testosterone, that's what grows their beards, right? So we shouldn't have that. We also have an abundance of the receptors on the top of our head here, right? So when a woman is producing too much testosterone, which comes from the ovaries, in fact, and even your adrenal glands, that testosterone starts circulating in the bloodstream. And so because you're producing so much, it goes to the receptor, it locks in, because remember I said hormones are like a lock and key with the receptor. It locks in and it starts stimulating hair growth, okay? It also causes the oil glands, the sebum glands, to enlarge. And so this is where the acne comes in PCOS, because when your oil glands enlarge, it becomes the perfect breeding ground for bacteria. It's warm, it's moist, and then the bacteria there cause an infection. So even though in those patients who maybe take an antibiotic for 3 months, say it clears up their skin, but because the testosterone is the driver, the acne could clear up, but then it could come back afterwards because you haven't treated the root cause of the problem. The hair loss that's seen in PMOS is because the receptors here on our scalp, the testosterone attaches to it, and it shrinks the hair follicle. So what ends up happening, the new hair finds it difficult to grow out, and you have now your normal fallout, but less regrowth. So in a patient with PMOS, we see this thinning, we see the path sort of widening, we can almost see through the hair, we can see the scalp. So in terms of natural treatments, again, if we go back to the root cause of the problem, insulin is again the driver of this, because what insulin does, it goes to our ovary and it locks into place, because remember the ovary has insulin receptors, and it makes these little cells called theca cells make more testosterone. And so the more sugar you eat, the worse your insulin resistance is, the more your ovaries are going to produce testosterone, the more acne you're going to get, the more hair loss you're going to get, the more hirsutism. If we look at natural treatments, so in terms of the homeopathic approach, there are homeopathic complexes and remedies that I prescribe to my patients to down-regulate the testosterone. Yes, I may prescribe certain medication to help clear the skin if they do suffer with acne, or certain remedies to help with growth, but doing those alone is just still superficial. We still want to get to the root cause of the problem, and we want to down-regulate the testosterone. There is some information where we've seen spearmint tea can help to down-regulate testosterone levels, but in certain cases when the testosterone is quite high, spearmint tea is not good enough, right? There are some research papers that show a herb called saw palmetto, that's a plant, can also be of assistance, but also it's very dependent on what the patient's level is. So that's where I would test a patient for their testosterone, their free and total testosterone, and look at their level and treat them accordingly. Another interesting thing and something that I think we should chat about, although look, birth control is not in my scope of practice. I'm not opposed to using or patients using oral birth control. The reason why it's prescribed to patients, because this question did come up, why is the pill prescribed? Is it treating my PMOS? So it's used as management for PMOS. It does not treat your PCOS or PMOS. What the pill does, if we're talking about testosterone, it actually causes your liver to produce something called sex hormone binding globulin. And that globulin binds to testosterone. So if a young girl is starting to show symptoms of PMOS and she's getting a bit of hair growth and some acne and hair loss, maybe she goes to the dermatologist before she's going to the gynae. The reason why the pill is given is because what will happen is that globulin starts to attach to testosterone. It doesn't attach here. It doesn't attach to these receptors. So my skin will clear, my hair will stop falling, my hirsutism will reduce. The problem is when you come off the pill, the testosterone was always still there. It was always still in the bloodstream, right? It didn't disappear. We just didn't see the symptom of it. So it's still circulating there. So when you come off birth control, eventually the testosterone goes back to those receptors and can cause the symptom again. And that's why I keep going back to talking about treating the root cause of the problem, insulin and the testosterone, rather than just saying, oh, I have acne or I have hirsutism, let me do laser. Because again, you might be killing the follicle and you won't see the hair growth, but what's happening inside is still present.
It's really fascinating. And just a comment before the next question for everyone in the room. I myself have PMOS, so one of the big reasons why I started this platform in the first place, and I'm learning some new stuff today that I haven't heard. I'd never heard of
Hirsutism. It is a bit of a tongue twister. Hirsutism.
So this is a bit of a, I guess, a comment, and I think you did go into the bit, but the person said, you mentioned there's no cure for PMOS yet. There are people on social media, doctors, influencers, and I think you also mentioned it, that have claimed to have reversed it. So what are your thoughts? So what is the difference there?
Yeah, sure. No, I totally understand. So when we talk about when we say the word cure implies that I'll never get that condition again. I went to the doctor, I got diagnosed with something, I took a medication, and I'm cured. I will never have that problem again. With PMOS, it's a syndrome, so it's really complex. And as I mentioned before, as women, we are so sensitive to stress that I've reversed PMOS in countless patients. Like I tell them, this is where we need to get to. You need to get to a point where if you go to another doctor and they do all the checks on you, they shouldn't even pick up that you've had this. This is what we need to work towards. But it's so important to understand that if you start to neglect your health, if you start to eat badly, if you stop exercising, if you stop taking the maintenance vitamins that should be taken after, we've completed treatment, if you neglect yourself, I spoke about mental health as well, it could come back. And there are patients who are probably on here who have said that, like they were feeling well, and then slowly the acne starts coming back, or if they had hirsutism, or they start missing a period, and one period then it's like a few months later, and then another period is missing. So the word cure means that I will never have that problem again. I've been cured. But we can use the word almost like remission with patients who have PMOS to say, I'm symptom free. I have good hormone levels. My bloods are all good. I'm regular on my menstrual cycle. When I go for my annual ultrasound, there's no multiple follicles. I have the correct amount. They all look good. So all your checks are fine. Your PCOS or your PMOS is gone, but it can come back. That's the difference. That when we say there's no cure for PMOS.
That makes a lot of sense. Thank you. There are a lot of questions still in the chat. I just wanted to check with you, Doctor, if there was more you wanted to sort of just go into, or should I continue with the questions?
So let me just see, because we were touching on most of the lifestyle. Let me see, we've gone through all of this. I did get some questions that were sent to me on social media regarding the homeopathic approach. So if I can just quickly go
Going to
through that
Sure.
and what's the difference, because a lot of people don't even know what homeopathy is. So the homeopathic approach, homeopathic medicine firstly is derived from natural resources. And so those plants or minerals have been tested and investigated to see what are the medicinal properties of those plants. So when we then give it to an individual, we can now shift different hormones. We can now bring about healing in that person. So whether it be, like we're saying, trying to regulate ovulation, to get a regular menstrual cycle, whether it be to down-regulate testosterone to help clear their acne, hirsutism, hair loss, whether it be using supplements like inositol to help with insulin resistance. It's important that we try to bring about balance, and that's what we do in homeopathy. The difference between homeopathic medication and what we say is mainstream and what's commonly prescribed is that we aim to get you off of medication. As a homeopath, I don't want you to be on medication. We aim to heal you and shift and get you to a point where, like I said, you're symptom free, and then we take away the medication. You don't need to be on it in order to have those regular periods. If we do look at birth control, remember that in PMOS, there's a problem with ovulation, that person is not ovulating. Birth control has its benefits because it does help clear up some symptoms where you won't see it, but like I mentioned, it may still be there. Of course, if one doesn't want to fall pregnant, you're getting the benefit of the contraceptive benefit from it, which is what it's intended for. And of course, it doesn't then allow the lining to build up over a long period of time. You get a withdrawal bleed. But the oral birth control is designed to prevent ovulation. And this is actually the opposite to what we want in PMOS. We want you to ovulate. We need you to ovulate. We need to grow those follicles and release those eggs. That's really important. And in homeopathy, this is what we're aiming to do. We pro what the body should be doing. So this is what we try to shift. So again, the medication and the protocols are very individualized. Because I get patients who may come to me who don't have periods at all, or it's irregular, or they do have prolonged bleeding because of low progesterone levels, because of the lack of ovulation. So every person gets a different treatment plan, basically. I think that's really important to understand that everyone needs to be treated as an individual. We can't just be giving like this blanket script to everybody if we are going to help women treat this and make them well again.
Great. I'm totally shocked to hear that the pill actually stops you from ovulating.
Well, that's how it works as birth control. That's how
I
it
had
prevents
no
you from
idea.
falling pregnant.
That's crazy. So yeah, the next question, someone is also actually talking about the pill when they say, when doctors say the pill masks the symptoms of PCOS or PMOS, does this mean when coming off the pill, one would be diagnosed with PCOS? And then the second part of the question, which is, I know you already went into this a little bit, maybe you can repeat it, is carbs in a diet the devil? Lots of contradictory research done on this. Should carbs be severely restricted, or should it be incorporated in a specific way?
Okay, let's answer the first part of that question. Just repeat the first part.
Sure. When doctors say the pill masks the symptoms of PMOS, does it mean when coming off the pill, one would be diagnosed with PCOS?
So look, it is very much what that individual is doing, because I get patients who will be really good when it comes to their diet and lifestyle. They'll be exercising, they're doing everything well on the pill. So then when they do come off the pill, hopefully they end up having regular periods and maybe their acne doesn't come back. But it also depends on how bad or how progressed their PMOS was, because I see this issue a lot where maybe a young woman went maybe in her teens onto the pill for her acne. So it cleared her acne. So when they use the term masked, it almost means that the symptom has gone away. So I, as an individual, I can't see my acne when I look in the mirror, but internally, the disease process that causes the acne is still happening. So it's masking it. I can't see it. I can't feel it, but it's still there. So that's what they mean by mask. So yeah, it's important to understand that if you're going on the pill for hormonal issues, that yes, it definitely can come back. I see this problem. And then it's women jumping on and off because it's like, okay, I want to give my body a break. I want to come off the pill. I stop the pill, and within 3 months, my acne is back. So I don't want to live with acne, so I'm going to go off. I'm going to go back onto the pill. And then this yo-yoing can happen almost like 10 to 15 years. And then a woman gets to a point where she says, I want to try and conceive now. I want to fall pregnant. And they come off, and there could be lack of ovulation, because that's what happens in PMOS. The acne comes back. But now what do I do? Because my only option way back when was the pill, but I can't be on the pill now because I want to fall pregnant. So it's always important to try and treat the real problem instead of masking it. I'm all for the pill. If a patient comes to me and she says, I have PMOS, but I also don't want to fall pregnant. I'm sexually active. I don't want to fall pregnant. Can you treat me while I'm on the pill? Yes, absolutely. We can do that because we are then treating internally, we're treating the root cause of the problem, even though she may be on the pill. So when she comes off the pill, she's less likely to get a rebound of those symptoms.
Okay.
That's important. And then your question about the carbs.
Yes.
So what I said earlier is that carbs are not the devil, right? It's not about doing low carb or keto or banting. Something we need to understand is the relationship that we have with food needs to be better, right? I don't believe in saying cheat meals, right? Because cheating implies you're doing something wrong, right? We need to now shift our thinking and saying, I want to eat the right carbs. It's not about low carbs. I want to eat the right carbs. So understanding food groups is actually really important. A lot of patients don't know what are proteins, what are carbohydrates, what are fats. So your carbohydrates are all your fruit and veggies, your grains. So that would then fall your wheat, your quinoa, your rice, your oats. All the grains fall into the carbs, right? It's the quantity at which you're eating it that becomes the problem. And what carbs are you eating that becomes the problem? So that's why I emphasize to patients saying, before we say, I'm going to make a pasta for dinner, instead change your mindset and say, what protein am I going to have for supper? What can I pair this with? And then you're more likely to then prioritize your protein intake versus your carbohydrate intake. We're very good at that. You go to a restaurant, you can go for a pizza or a pasta or something that has a carbohydrate, instead of saying, okay, what protein can I have here first, right? So I think knowing your food groups is really important, and not making it seem like carbohydrates are evil. We need carbohydrates. Our body needs carbohydrates, but when we're talking about PMOS and insulin resistance, what we're trying to really achieve, if a woman is trying to lose fat mass, we want to now tell the body, no, I don't want to use the carbs that I'm eating for energy. I need you to take the fat out of storage and use that as energy. So this is why it is important to cut down on the quick fix, the sugar, the white flour, because your body will use that first. Your body is not going to take out fat from storage. It's going to say, well, I've just eaten some sugar, and that's why your body will crave sugar, because it's way easier to get you to eat the sugar and use that for energy versus now this whole process of the body, taking the fat out, converting it back, and taking it to your muscles. So the right carbs are really important.
Makes a lot of sense. The next question is something that I think, if I was listening correct, you can tell me if I'm answering correctly, but you can also obviously go after. But someone asked, I get my periods every month because of the Provera pill my gynae gave me, but I don't know when I'm ovulating. I've been eating the proper way, but still nothing. And now, am I correct? You don't ovulate when you're on the pill?
Yes. So when you are on, so Provera is not a birth control.
Okay.
Provera is a progesterone pill.
Okay.
And so what Provera does, it builds up the lining. So I was showing you this little diagram that I show my patients. It's time for it. So when we are looking at this diagram, right? Well, I'm trying not to get the light in. The reason why I'm showing you this and how it's going to relate to what I'm talking about with Provera, in the first phase, the follicular phase, that phase is focused on growing this follicle, which has the little egg in. As soon as we ovulate, we produce this hormone progesterone. You can see it goes up quite high in the luteal phase. That only will happen if you ovulate. We will only produce progesterone, a good amount, if we ovulate. So if you are not ovulating, most likely you're not going to produce progesterone. What Provera does, it almost mimics that, what I showed you. It'll build up your lining. So you take it for a few days, and then when you stop taking it, you bleed. So it's building, it's just to allow the shedding of your lining. How I would check and how doctors should check if an individual is ovulating, we would take an average of their menstrual cycle. So the lady said that she does have her period every month, but it's most likely Provera induced. It's probably not a true period. A true period, remember, comes when we've ovulated but not fallen pregnant. So what I would do in this patient, we would then remove the need to take Provera, allow her body to just, not regulate, but allow her body to sort of detox, if I can say, from any medication. So even with hormone testing, I would only do it in a patient after she's been off the pill for 3 months, see what happens. If she doesn't have a period, we would do hormone testing. If a patient comes to me and she says, I've been diagnosed with PMOS, I'm trying to fall pregnant, but I don't know if I'm ovulating, then we do a day 21 test, right? Because if we look back at this diagram, day 21 is when progesterone peaks, okay? And so if we do a blood test on that day and we see that the progesterone level is really high, then we know that that patient ovulated, which is great. That's what we want in any individual, especially with PMOS. The thing is, you can't actually properly diagnose somebody if they're on the pill, because you can't do hormone testing. You also can't check their testosterone level when they're on the birth control pill, because remember, it makes it a lot lower than it should be. It's not a true reflection. So you actually can't properly diagnose somebody with PMOS if they are on the birth control pill.
Okay, interesting. We have about 15 minutes left, so we're going to try get through as many questions as we can. This one's a bit long, and I do think you have delved into a lot of it as well, but if there's anything else that comes up. Hi, I've lived with PCOS for 15 years. I was diagnosed by a gynecologist at age 13, via scan due to weeks of heavy bleeding. I was prescribed birth control and have used it ever since. Whenever I try to stop the pill, my acne worsens, I get severe headaches, mood changes, and my period becomes highly irregular. Currently, I'm dealing with swelling in my feet, hair loss, weight gain, headaches, and irregular sleep patterns. Could you please recommend an optimal eating plan for these symptoms, as well as essential medications for weight loss, hair loss, and acne management? So I know you have gone into most of this, but
yeah. And look, again, as much as it's a good question, it's very difficult for me to answer that question. And the reason for that, in my scope of practice, it's so individualized. I would sit with this person for an hour and go through everything when it comes to when are these headaches or migraines happening, what is happening with her sleep, what is her stress levels like, what is she currently eating, do an in-body scan, look at what her body composition is. So there isn't one simple answer to that question. Also, we would have to do blood tests in this patient because then we need to see what is her testosterone levels, what is the insulin level, decide on what supplementation is required after that. So it's not a simple, here's a script, go on your way, even with the diet. Look, the takeaway though, for what I can say for the woman here today in terms of PCOS with the diet, if they can start doing what I've suggested in terms of starting to reduce the refined sugar. And sometimes we need that like self-motivation or self-talk where we physically tell ourselves that we're about to reach out. Because sometimes we can do this mindlessly, like take a chocolate from the cupboard or, biscuits and whatever it is. But we need to almost like take a step back and like, no, I'm not going to have this. And it can be very difficult in the beginning. So if we can start with just the simple changes of saying, I'm going to prioritize my sleep. I'm not going to sit on social media in my bed till midnight every day scrolling. I'm going to prioritize my sleep. And if she could make those changes in the meantime, sleep every day at the same time, wake up every day at the same time, start prioritizing her protein, start moving her muscles, those will start to have some sort of positive effect. But I can see based on everything else that she's experiencing, she definitely needs individualized treatment.
Okay, thank you. The next question is it true that you could be born with this syndrome, but symptoms only show more when you get your first period? Or could it be that you only get it at your first period?
No, so you can't be born with PMOS. Like I mentioned before, we have the genetic predisposition. So that means like if our mom has diabetes or if she had PCOS or insulin resistance, we would definitely be at higher risk of developing it. I actually have seen it many times in practice with very young girls who have come to me where moms have brought them in. Maybe they are already slightly overweight. We're seeing the pigmentation around the neck that's associated with insulin resistance. That's called acanthosis nigricans. So we start seeing some symptoms before puberty. We can, but you definitely are not born with it. There's things that we do in our lifestyle that will trigger you to actually get it when you go into puberty.
Okay. What are your thoughts on the Mirena? My gynae advised me to have it inserted after my second child, not so much for contraceptive purposes, but rather for the management of PMOS.
So it won't necessarily manage PMOS because it's not like an oral birth control pill. It's not going to do anything for testosterone, right? However, the difference between a Mirena and oral birth control is that the benefit of a Mirena is that you still ovulate. So if I had to recommend a birth control to somebody who needs it, they don't want to fall pregnant, I would say a Mirena would still be better than an oral birth control because the problem in PMOS is ovulation. So you don't want to be taking something that's going to stop you from ovulating. So Mirena would be a good option. But again, we know now that the main driver of PMOS is insulin. So that patient getting her insulin checked and making sure she's on the right supplementation would benefit her a bit better.
Are there platforms for healthcare workers with an interest in PMOS and fertility that you could suggest joining or subscribing to?
Sure, that's a bit of a tricky one. Normally it's more formal, at your institutions, but Yeah, I would probably have to maybe send you some information after this, and maybe you can forward it on to them.
Yeah, happy to. What I will do also, Dr. Naidoo, you mentioned the test that would be good for all of us to take and all of that. So I will share that. I will get that information from you and share that with everyone in a post webinar mailer. Okay, next, let's see how many questions we can get through in 10 minutes. So do you have any recommendations for doctors who treat PMOS holistically with this approach based in Johannesburg? And the question right under that is, do you have recommendations for doctors who treat PMOS holistically with this approach based in Cape Town or do virtual consultations? This is for my 16-year-old daughter that's been on quite a journey. So this is your time to also plug yourself.
Well, yeah.
Yeah, exactly.
So, look, I do treat patients all over South Africa, and if I can say globally as well, because I have patients who live in Dubai and France and Australia. It would literally just mean getting the medication to them where we courier. But I treat a fair amount of patients in Joburg, Cape Town, all over SA, because we do it virtually. The only thing that would be different is that they're physically not sitting in front of me, but we would be talking like this. I send patients for blood tests, send them a form, they go have it done. So the quality of the treatment would still be there, although they're not physically here. But I think there are patients who want to have somebody physically there. I get it. It's not always the ideal. You want to see somebody. I don't know anyone personally who specializes in PMOS. Of course, there are many homeopaths in Cape Town and Johannesburg. So I think it would just be that person researching, I suppose, to find somebody that would. But again, I conduct virtual consults. We courier meditation throughout South Africa. But yeah, that's that's my little input there.
Okay, great. Yeah, I would really encourage you, everyone on the call today, to get in touch with Dr. Tharushka to have that conversation. Something we're doing as Own Your Hormones is that we are conducting research to put together a list of professionals from all different types of perspectives, homeopathic, normal Western, traditional medicine, a list so that people can go, women like yourselves can go and look and maybe find the right person for you in person and online. So yeah, keep an eye out for that. That's something we are working on. Okay. Is Insumax Q a good alternative to using glucophage? Yeah.
So it's not an alternative. You can't replace it. And the reason for this is when we look at randomized controlled trials, we need a dose of 4,000 milligrams of inositol. So that would be myo to D-chiro in the 40:1 ratio in order to have a clinical effect. So Insumax only has 1,000 milligrams of myo-inositol, so it definitely wouldn't replace glucophage. But in saying that, I put patients onto Insumax once we get to a point where all their bloods are normal. So if they initially maybe had insulin resistance, of course, we'll work on that. But once they're at a point where they're healthy, they're having a healthy regular menstrual cycle, everything is looking good. Remember, I said there has to be that management thereafter to prevent you from getting PMOS again. Because when you in that remission state, you need to still support yourself. And that is when I would recommend Insumax, because 1,000 milligrams is not going to do much for you. That is more for maintenance dose, really, when you have normal insulin levels. If you have insulin resistance, it's not going to do much for you.
Okay. Someone asked, can homeopathy help someone in their early 30s restore menses that stopped 14 years ago?
So it really depends on what caused it to stop. It could be PMOS. It could be what we call HA, hypothalamic amenorrhea, where there's now no communication between your brain and your ovaries, because it's our brain that actually tells our ovaries to, make eggs, to grow those eggs. It sends follicle stimulating hormone there. Sorry, so just make this big again. So with somebody who hasn't had a menses for that amount of time, we have to dig deep and see what could be causing it. If it is PMOS, or is it another underlying issue? There are some patients who have high prolactin levels, which also suppress menstruation. So it's not a simple task. There needs to be some investigative work. But I've seen many patients who come to me for amenorrhea, maybe not because they have PMOS, but for other reasons, where we are able to restore ovulation, and then therefore they will have menstruation.
Okay. Someone asked here, are there any recommendations on a homeopathic route to take for anxiety and depression? And I just want to throw this in there as well, Dr. Naidoo. I also heard that PMOS, a lot of it comes from trauma. So I don't know if that is a true statement or not, but I'd love to know if that is true. And then, yeah, obviously, if you have any homeopathic routes to treat anxiety and depression.
So if we just talk about the first part of that, in terms of anxiety and depression, if we look at how it can be related to our hormones. So again, if I go back to this graph here, this diagram, there's two phases to our menstrual cycle, the follicular phase and the luteal phase. In the follicular phase, that first 2 weeks, our ovaries produce estrogen. If we talk about our mental state in the first 2 weeks, maybe during our period, we're feeling a little bit tired, a little bit low, but the role of estrogen, because remember, the whole menstrual cycle is really focused on reproduction, survival as a human being. So what's it going to do? When we have the right amount of estrogen, we feel confident, we feel happy, we have higher libido, we find interest in our partners because it's trying to it's trying to convince you to have intercourse for reproduction, right? So we feel good about ourselves. We even feel quite productive with our work, like Superwoman. We can do so many tasks, okay? So that's the first 2 weeks of the menstrual cycle. The luteal phase now, where we ovulate, we have a drop in estrogen, but then we have a rise in progesterone. That hormone is like our cool, we should feel like cool, calm, collected. We still feel pretty chilled when we have progesterone. Maybe not the same libido and energy that we did in the follicular phase, but we still feel quite good. Where PMS sets in is by day 21, where the body picks up, there's no pregnancy, so we can start prepping the body for a period, and those hormone levels drop. We feel irritable, we feel sad because now progesterone level, we can feel really emotional. We can almost feel like a different person. In severe cases, it's called PMDD. You can feel anger, you can feel rage because your hormone levels are dropping. And then when you have your period, and then the whole cycle starts again. In PMOS, the reason why some women can feel like this all the time, and in fact, the anxiety and depression is due to their hormones and not because of something else, is because they're not ovulating. They're not producing the estrogen that they should when they getting to like day 14. They have low libido. They have low confidence. They're feeling sad. And they also, because they're not ovulating, they're not producing progesterone. So they won't feel that chilled, relaxed feeling, that sense of calm. They feel on edge, they feel anxious. Although some patients will tell me, I don't have anything to feel anxious about, but I wake up feeling this way. Like I'm feeling sad, but I don't have a reason to be feeling sad. And it's because of the lack of ovulation and the lack of the fluctuations of those hormones. So when we restore that, as much as we may be looking at the physical symptoms, a lot of the time, the mental and emotional aspect of a patient really improves as well. Like patients will say, I'm feeling good about myself again. My confidence level has improved. The way I think now, I don't have brain fog anymore. That all improves as we start to regulate the hormones.
Okay, I'm trying to ask the questions that haven't really been asked yet, but we have 1 more minute to go. So I'm going to do one more question. I'm so sorry, ladies. It is important. I know we could keep going on for hours and hours, but I know that everyone also has to get back to normal life. So I'm going to choose one question. Give me 1 second. Let me see. Is the pill not unsafe for women over 35 due to blood clots?
That's it's a difficult question to answer because you see, with every person as an individual, not everybody gets the blood clots. It can happen even under the age of 35. There's no test that you can really do to tell you if you would get it or not either. So it's almost like you've got to take the chance. But yeah, it's a difficult question, that one, to answer.
Okay. I'm going to do 2 questions in one, and then we're done.
Okay.
But one of the questions is P-Cositol recommended as a beginner? And the other question is, what is your thoughts on mushroom capsules like maitake? I think that's the correct pronunciation.
Okay, so with P-Cositol, look, I don't really want to talk about specific products here, but I would say it does have 4,000 milligrams of inositol in it, but there are other various reasons that I don't actually recommend it anymore.
Okay. And then the mushroom.
Mushrooms are powerful. So I don't think there's much research yet with the benefit that it could have on PMOS, but maybe there's some scope for somebody to do some research into that. They are really powerful, but it's always best to use medicinal mushrooms under the care of a healthcare practitioner. Although I know they are readily available online, because there's so many products online. I know there's many websites selling PCOS products as well. But remember that these products are not really regulated, and it's always best to check with your healthcare practitioner or your doctor and do the blood test first, because you could be taking the wrong thing. Just because it's natural doesn't mean it's safe. Like, there are plenty of plants out there that can kill you or cause liver toxicity or kidney failure. So don't think the word natural. I mean, we've got heavy metals that are natural, like it doesn't mean it's safe. So don't assume when you see something online for hormonal condition that it's okay to take. I always advise that you get advice from somebody who understands it and knows and is maybe knowledgeable when it comes to those supplementations.
Okay, thank you so much. I know we couldn't get through everybody's questions. As much as we would love to go for the whole day, like I said, everyone is working, parents. Dr. Naidoo obviously has her patients. So yeah, I want to say a huge thank you to you, Dr. Naidoo, for just giving us such a generous and clear breakdown of PMOS. These are exactly the kinds of conversations we set to create with Own Your Hormones, and really having the opportunity to take what usually stays inside a consultation room, always very fragmented online, and putting it in front of women who need it. My biggest takeaway today was really understanding that PMOS is very individual. So it is worth seeing someone professional, asking the questions that you specifically are going through, and spending a bit of money on the tests that really are going to give you the answers that you need. Again, please reach out to Dr. Naidoo to explore working with her further. I will have the resources as well as her contact details in an email for all of you that will come out in the next day or two. And with that being said, thank you to everyone who's joined us today for your time and your questions. Before you go, keep an eye out on our website or our Instagram page. Our next webinar that we will be talking about is something very sensitive, but something that we feel is very silent, and that's talking about miscarriage and hormonal health. So if that is something that you or anyone in your life would like to hear more about, then definitely keep a lookout and register for that. But with that being said, again, a big thank you to you, Dr. Naidoo. We really, really appreciate it. And yeah, thank you again to all of you, and we'll see you soon. Have a
Thank you so
wonderful
much,
day.
Sarah Jane. Appreciate it so much for the opportunity. And I think even if one person went away today with some benefit, some information, that's all we needed to achieve, because I really feel like education is where we need, what we need to strive for, because when you have that knowledge, that it empowers you. So I'm so happy and grateful to you for opening up this channel and this avenue for so many women out there who have these conditions.
Thank you very much. It's a pleasure, and I'm grateful to you. And once again, we've recorded today's session, so also keep an eye on our page, our website. We will be uploading this onto our YouTube channel, which, by the way, was a suggestion from Dr. Tharushka. So thank you for that. And yeah, we'll see you all soon, and thank you again.
Okay. Take
Bye,
care.
everybody.
Bye.